Hi, that's Walid Tawfiq. Another case scenario. We have a 69 years old man who had a left knee pain for the last 5 years. He had exhausted the non-operative treatment and he needs a surgical option for his condition. So this is a plain radiograph AP view of the left knee showing advanced tricompartmental or advanced osteoarthritic changes in the left knee. I can see there is a metal work in the distal end of the femur. So I would like to see other view and the full length of the femur plane radiograph two views. So I would do my assessment by taking history and examine the patient and arrange for possible proper investigation. My history taking involved with the present complaint as regards ensuring the pain is originating from the knee. I will ask history about red flags that suggest a serious pathology. I will do an Oxford knee score, what treatment so far received, and what's the patient limitations and expectations. Past knee history includes the previous injury, treatment, surgery, and what the outcome. I need to take detailed history about the surgical intervention that had been involved, the end and indication, duration, and any perioperative wound healing issues, and what is the outcome. I will take other joint history, especially the ipsilateral hip, past medical history, including presence or absence of other comorbidities. Examination, I will generally look for the patient BMI. Local, I will look for overall alignment, skin condition, scars of previous surgery, presence of any signs suggested previous healed sinuses or infection. Check his gait and extensor mechanism and patellar tracking. Feel for point of tenderness and effusion. Check the range of movement towards the fixed flexion deformity, and check the stability for cruciatal, the collaterals, and the rotational profile. I will do a hip and neurovascular examination, spine examination. My investigation will be in the form of imaging and lab. Image, I will do a plain radiograph, weight bearing full views for the involved limb, which is the left side, and I will do a full length long leg alignment. I will do a CT scan to check for the rotational profile and the presence or absence of bony defect. I would like to review any previous images for this patient if available on my system. Lab investigation, I will do a basic blood, including full blood count, use and ease, cross-match blood if I embark on surgery, and if in this situation he had a metal work previously or previous surgery, I will do a CRP to exclude any infection. My treatment options, the aim of treatment is to any intervention, I need to improve the patient quality of life by achieving a pain-free, stable knee with restoration of the normal mechanical alignment and normal patellar tracking, joint line and balancing the gaps in flexion extension. The guidance is a nice guidelines, and the principles for this particular case is a complex primary knee replacement and the outcome of intervention satisfaction rate up to 90%, survival up to 15 years for this procedure. And the general principles, pre-operative planning is the key to find the site and the size and the plan of deformity and the dealing accordingly. This patient had a metal work, so I might think about either single stage or two-stage procedure. However, I have to consider that metal plate is coming to the intermedullary check of the femur, so I might use extra helping tool like presence of navigation or patient-specific instrumentation. If I do it a single stage, or if it is a staged procedure, I will take the metal out, won't leave the wound to heal, and then I will do a second procedure, which is a knee replacement. Challenges need a multidisciplinary team, including the anesthetic review to optimize the patient pre-operative. I will involve a senior knee surgeon to get it right first time with pre-operative planning and the other specialties based on the patient comorbidities. Intraoperative, I will do a formal exposure. Sorry, in the pre-operative planning, I had to confirm that the size of the deformity is less or plus 20 degrees. It is present on the diaphyseal or metaphyseal. And if it is present, what's the plan of the deformity? And the options either to do is intra-articular correction of everything if the deformity is away from the metaphysis and less than 20 degree. If it is in the metaphyseal area, large deformity, I can address that either by single or staged procedure of with knee replacement. If it is far away, like an extrametaphyseal, if it is small, I will do an intra-articular correction. If it is large, I will do a two-stage procedure. I have to always consider custom-made procedures if it's a complex deformity, not applicable for this case. My post-operative rehab will be a wound care prolonged this patient because of extensive soft tissue condition and scarring may need a prolonged rehabilitation and routine post-operative DVT prophylaxis.